I think of this as a possibility of using this device for subacute neuralgias, so post-surgical neuralgias. What we see at our hospital tends to be related to sarcoma resections. And then we're thinking about some of these chronic pain syndromes. So really, if you think you have a neuropathic pain syndrome that's involved, theoretically, this is a target. So for myalgia paresthetica, you have lateral cutaneous nerve, post-herniography pain, either the ilioinguinal nerve or you're targeting T11 or T12 subcostal nerve. We think of it as a neural target phenomenon. I've done this for post-symptomatic neuralgia. We've done it for our first case for post-mastectomy-related pain, intercostal brachial neuralgia. So we have some unique things that we use this device for, but by and large, I think for the vast majority of the patients or people you're thinking about using this for, you'll be targeting the femoral nerve, the popliteal nerve, the suprascapular and axillary nerve for shoulder-related pain. These nerves tend to be easier to see under ultrasound. The targets are easier. You have a variable distance to get to the nerve, which allows you time to see your needle under ultrasound. And also under ultrasound, the neural targets are a little bit easier to teach. So if you're getting to know how to use an ultrasound machine, I don't want to necessarily have to teach you where the saphenous nerve is. That's something you'll learn over time. But the femoral nerve is easier to teach. So when you think about using this device, think about how can I use my ultrasound machine, what skills do I have, and which nerves are the easiest to visualize. And this is the finding the stimulating needle. We're using the ultrasound machine here. It's going very quickly. Here is the external battery that you will use as you're testing. You'll have that inside, usually it's outside your sterile field. The testing system we have here is they have a proprietary number that the tester can increase using a representative. And the idea under ultrasound is to find a location that stimulates your entire nerve, but giving a pleasurable sensation. It doesn't necessarily have to overcome the pain quite yet, but you want to be able to have a setting that your patient can tolerate. You'll remove the finder needle and then place the actual needle tip here. Now the lead sits on the back of that orifice, and probably one of the most important couple of things you want to do here is you want to have control of the cannula, and then you'll do your testing again. If you have a appropriate testing, if you clamp this device, that's similar feeling to what you had in your test, you'll deploy that lead. Again, we'll talk about some of the settings in the next slide. But when you have this appropriate test stimulation, you'll tape this in place with a little bit of pressure. You'll take the lead out. You'll tape it in place. If the video is going a little slower, you'll reclamp it, tape it in place, and then patients are able to have do as long as you protect the tegaderm that you'll see here, able to put wash themselves, have a shower. They'll change their tegaderms every few days. I tend to use Dermabond at the exit site of the, I echo the same things the other physicians have seen. We haven't seen infection. I haven't seen even erythema. I think one patient might have had a little bit of erythema at the exiting site, but it's been fairly surprising that we haven't seen a significant number of infections, which I think echoes to the quality of the engineering of the device.